Okay, welcome to Chapter 11, dealing with the exocrine pancreas, gallbladder, and liver. We're going to begin with the exocrine pancreas. Now remember that the pancreas is sort of two organs in one. There's an exocrine pancreas that's going to produce the enzymes necessary for digestion, while there's also an endocrine pancreas which would secrete hormones into the blood. In this particular chapter, we're only going to discuss the exocrine pancreas, and we'll leave the endocrine pancreas for the endocrine chapter. The first disorder is annular pancreas. This is a developmental malformation. Here the pancreas forms a ring around the duodenum, leading to a risk of duodenal obstruction. It's a fairly high-yield topic to show up on examinations because of the fact that it is a good tie-in with embryology. Now let's go back to the normal and remind ourselves that the pancreas sits here in this sort of C-shaped bend of the proximal duodenum, and it's slightly posterior to the duodenum. Now imagine if the pancreas were to be shifted forward and then were to turn on itself and to wrap around the duodenum, then this would form a ring around the duodenum, which could potentially lead to duodenal obstruction. And that's called an annular pancreas, when sort of the head of the pancreas bends around and wraps around the duodenum. Acute pancreatitis is when you get inflammation and hemorrhage of the pancreas. Now basically the issue here is that you get autodigestion of the pancreas by the pancreatic enzymes. So really it's a story of premature activation of the pancreatic enzymes. Now recall that the pancreas produces digestive enzymes, and those enzymes are produced in an inactive form. It's not until they get into the duodenum that the activation actually occurs. However, if there was a premature activation within the pancreas, then we would have autodigestion of the pancreas, and that's called acute pancreatitis. Now, it's very high yield to note for the purposes of examinations that the first enzyme that classically would get activated would be trypsin, and then trypsin would subsequently activate all the other enzymes. When patients have acute pancreatitis, they get the autodigestion of the pancreas, and this results in a liquefactive necrosis of the pancreas with extensive hemorrhage. Hemorrhage because there's a lot of blood vessels within the pancreas. So we're going to get a liquefactive necrosis of the pancreas itself. At the same time, remember that surrounding the pancreas is adipose tissue, and these digestive enzymes would also digest the adipose tissue, releasing the fatty acids. The release of fatty acids would then undergo saponification, and that is called fat necrosis. And so you get two types of necrosis in pancreatitis. You get liquefactive necrosis of the pancreas itself, and then fat necrosis of the peripancreatic fat. The two most common causes of acute pancreatitis are alcohol and gallstones. The idea here is that alcohol creates contraction at the sphincter of Oddi at the ampulla that enters into the duodenum. Now recall that the pancreatic enzymes, they drain via the pancreatic duct, eventually entering the ampulla and then going into the duodenum. If there's contraction of the sphincter of Oddi here, this would decrease the drainage of the pancreas, increasing the risk of premature activation of the enzymes. An additional common cause is gallstones. Again, if you have a gallstone that blocks here at the ampulla, this would block the ability of the pancreas to drain, and of course, a decreased drainage of the pancreas would increase the risk for premature activation of the enzymes. Other causes of acute pancreatitis include trauma. One of the high-yield examples of trauma to be aware of would be automobile accidents in children. Now imagine if a child is wearing their seatbelt such that it overlies the abdomen instead of the pelvis, then were an accident to occur, the seatbelt would actually pull on the abdomen, compressing the abdominal structures including the pancreas. This could then lead to premature activation of pancreatic enzymes. Hypercalcemia and hyperlipidemia are also important causes of acute pancreatitis. The way by which I remember hypercalcemia is to just remember that calcium is an activator of enzymes. And so if there's a high calcium within the blood, obviously that high calcium could potentially activate the pancreatic enzymes. Drugs can also cause acute pancreatitis. The venom from a scorpion can also cause acute pancreatitis. Recall that the mumps virus has a propensity to infect the pancreas, increasing the risk for acute pancreatitis. And finally, rupture of a posterior duodenal ulcer can result in pancreatitis, and that's because the head of the pancreas sits slightly posterior to the duodenum. When a patient presents with acute pancreatitis, they classically have epigastric abdominal pain that radiates to the back. In addition, they'll have nausea and vomiting. There can be periumbilical and flank hemorrhage. The idea here is that the necrosis can spread into the periumbilical soft tissues in the retroperitoneum, giving you this periumbilical and flank hemorrhage as you get destruction of the blood vessels in this region as well. Laboratory examination would show an elevation of serum lipase and amylase. Again, both of these are enzymes that come from the pancreas, but it's important to note that lipase is more specific for pancreatic damage, and that's because amylase could also be seen if there was damage to the salivary gland. Finally, on laboratory exam, there could be hypocalcemia. Now, the idea here is that when you have acute pancreatitis, you get liquefactive necrosis of the pancreas, but fat necrosis of the peripancreatic fat. And that fat necrosis would lead to saponification, and saponification would use up calcium as calcium was deposited within the fat. So this eventually could result in a hypocalcemia. In fact, having hypocalcemia is a poor prognostic indicator because of the fact that it indicates that there's such severe necrosis that there's also necrosis of the peripancreatic fat. Complications of pancreatitis include shock. The idea here is that not only are you digesting the pancreas, but you're digesting the myriad of blood vessels present within the pancreas, and so that extensive hemorrhage could result in shock. In addition, there's going to be fluid sequestration from all of the tissue damage. A pancreatic pseudocyst is also a complication. In this particular case, you get fibrous tissue that surrounds liquefactive necrosis and pancreatic enzymes. So it's called a pseudocyst because it doesn't have a true lining. Instead, it's just fibrous tissue that walls off pancreatic enzymes and liquefactive necrosis. Now, these patients would present with acute pancreatitis, which eventually led to the progression of an abdominal mass and with persistence of the amylase enzyme. Now, of course, when the patient has acute pancreatitis, the amylase would go up, and then we would expect the amylase to go down as the bout of acute pancreatitis comes to a close. However, in this particular case, there would be persistence of the amylase enzyme. The further complication of a pancreatic pseudocyst is that it can rupture. And when it ruptures, you get release of all of those enzymes into the abdominal cavity, which then results in extensive hemorrhage within the abdominal cavity. Patients with acute pancreatitis can also develop a pancreatic abscess. This is usually due to E. coli, and it presents with abdominal pain, high fever, and a persistently elevated amylase in the face of a recent bout of acute pancreatitis. Finally, important complications are DIC and ARDS. Now, the way I remember this is that the pancreatic enzymes can potentially get into the blood, and so they can chew on the coag factors, activating them, giving the patient DIC. At the same time, the enzymes, when they're in the blood, can chew on the alveolar capillary interface, damaging the alveolar capillary interface, giving the patient ARDS, or acute respiratory distress syndrome. Chronic pancreatitis is usually due to recurrent bouts of acute pancreatitis. And so you can imagine as you keep getting bouts of acute pancreatitis, eventually you're going to get fibrosis of the pancreatic parenchyma, and that is called chronic pancreatitis. Now, the most common causes are alcohol in adults and cystic fibrosis in children. If you go back to your original list of causes of pancreatitis, you'll see that the vast majority of them would only occur once in a patient's lifetime. For example, if the patient had a drug that caused acute pancreatitis, you'd remove the drug. Obviously, a patient wouldn't get bit by scorpions more than once, for example. Additionally, trauma would only occur rarely in a patient's life. However, alcohol is something that patients have a difficult time giving up, and so multiple bouts of acute pancreatitis with alcohol can result in chronic pancreatitis. In the case of cystic fibrosis, there are thick secretions coming from the pancreas. This slows the ability of the pancreas to drain, and hence increasing the risk for early activation or premature activation of the pancreatic enzymes. It's important to note that many cases of chronic pancreatitis are idiopathic and we don't exactly know the cause. The clinical features of chronic pancreatitis are epigastric abdominal pain that radiates to the back, but in addition there'll be pancreatic insufficiency. Now, there are a couple of derivative points that arise from this notion of pancreatic insufficiency. Of course, if you damage the pancreatic parenchyma, you're not going to be able to produce the enzymes that the pancreas would normally make. Because you can't produce the enzymes, the first complication will be that the patients will get malabsorption with steatorrhea. Of course, you need the enzymes to assist in digestion, and so no enzymes is going to lead to malabsorption with increased fat within the stool or steatorrhea. At the same time, the patients will also develop fat-soluble vitamin deficiencies because if there's poor digestion of fat, you won't be able to absorb the fat-soluble vitamins A, E, D, and K. Now, one more derivative principle from pancreatic insufficiency. It's important to note that amylase and lipase, which were good markers of acute pancreatitis, are not useful for chronic pancreatitis, and that's because the vast majority of the pancreas has been destroyed, and so you're not making a lot of amylase and lipase to begin with. An additional feature of chronic pancreatitis will be that you'll have dystrophic calcifications of the pancreas. On imaging, you'll see this calcification wrapping around the pancreas, and often the pancreas can be massively calcified when there's chronic pancreatitis. If there's extensive damage to the pancreas, you'll eventually damage the islets, and when there's damage to the islets, the patient can present with secondary diabetes mellitus. However, this is a late complication. And finally, patients with chronic pancreatitis have an increased risk for pancreatic carcinoma. Pancreatic carcinoma is an adenocarcinoma that arises from the pancreatic ducts. Now remember, when you go back to your histology of the pancreas, you have ducts that are carrying the secretions, and then you have acini, which actually make the enzymes. And so this is an adenocarcinoma that arises from the pancreatic ducts. It's most commonly seen in the elderly. The average age is 70, and there are two major risk factors that you have to know. Number one, smoking, and number two, chronic pancreatitis, as I just mentioned on the prior slide. Patients with pancreatic carcinoma generally present late in the course. However, when they do present, they classically have epigastric abdominal pain and weight loss. Now, pancreatic carcinoma can arise within the head of the pancreas or the body or tail of the pancreas. When it arises within the head of the pancreas, the classic finding would be obstructive jaundice with pale stools and a palpable gallbladder. The idea here is that when you've got this tumor in the head of the pancreas, you're going to block the flow of bile. When you block the flow of bile, then whatever's present within the bile will leak out into the blood. And so because there's bilirubin in the bile, bilirubin, in particular conjugated bilirubin, will now leak out into the blood, giving the patient's jaundice. In addition, because bile does not leak out into the duodenum, you will not get mixing of bile with the stool, and hence because the stool receives its color from a derivative of the bilirubin, the stools will become pale in color. Finally, because there's blockage of this tract, you may get backup pressure into the gallbladder, which would expand the gallbladder, making it palpable. And so these are some of the key findings, as I stated here in the slide: obstructive jaundice with pale stools and a palpable gallbladder. Again, this would arise when tumors are present in the head of the pancreas. If a tumor is present in the body or the tail, there's a possibility for that tumor to knock out the islet cells of the pancreas, which are predominantly present in the body or the tail. And so those patients can present with secondary diabetes mellitus. Now remember that pancreatic carcinoma is a disease of the elderly. And so if you have a thin elderly person that presents with diabetes, you should think about the fact that that's not the demographic for a normal diabetic patient. Remember that type 2 diabetics are usually obese, and type 2 diabetics normally present in middle age, for example, the age of 40 or 45. And so if you have this thin elderly female on a board exam that all of a sudden presents with diabetes, think about pancreatic carcinoma as an important possibility, and that's particularly high yield for examination purposes. Additional clinical features of pancreatic carcinoma is that it can lead to pancreatitis. Of course, if the tumor blocks the pancreatic duct, that would decrease the drainage of the enzymes, increasing the risk for premature activation. Patients can also develop migratory thrombophlebitis. This presents as swelling, erythema, and tenderness in extremities, and it's seen in about 10% of patients. And finally, it's important to note that the serum tumor marker for pancreatic carcinoma is CA19-9. Treatment of pancreatic carcinoma involves en bloc removal of the head and neck of the pancreas, the proximal duodenum, and the gallbladder. So we can use our image here to highlight what would happen. Again, you would be removing the head and neck of the pancreas, the duodenum, and the gallbladder, and that's called the Whipple procedure. Now, it's important to note, however, that pancreatic carcinoma has a very poor prognosis, and in fact, the one-year survival is less than 10%. That concludes our section on pancreas.